a yearly follow-up from Sabine on her research. And I will, Pete, are people still logging on or not?
I'll let them in as they come in. I think it's safe to start, though. We have a lot of people in now.
Yeah. All right. Well, take it away, Sabine.
Okay, great. Thank you all. And I'll just share my screen here. All right. Thumbs up if you can see my PowerPoint. I'm going to start from the beginning.
It's good, Sabine.
Great. So, so as Lauretta said, my name is Sabine Franklin, and I am the Mellon Postdoctoral Fellow here at Wellesley College, which is in Wellesley, Massachusetts. I am based in the Africana Studies Department, and I have an interdisciplinary and transdisciplinary background of anthropology, history, political science, and economics, and of course in public health. So today I want to talk about this work in progress paper that I shared with you all. Broadly, you read the first half of it, section 1, which was the theory and kind of background about why, what do we mean by decolonizing public health, and why we need to decolonize public health. So, ideally what I had in mind for this paper is that I was thinking about submitting it to social science and medicine qualitative methods. So SSM has like different categories, different like spin out journals now that you can contribute to. And then they have one called qualitative methods. Ideally, it would be around 5K, but no more than 7K. And then that first part that you read is the context and kind of theory. And then the second part is how I'll describe my research methods and how it came to be. And really just appreciate any feedback that you guys have, any questions or comments. That's super appreciated just to get some, great minds to be thinking together. So part 2 of that paper, you saw that I kind of sectioned it out like A, B, C, D, E, and F, because that's basically my way of outlining the story I want to tell about the research methods to try to decolonize my study. So part A is that background or story of how it came to be as a research student in my first year of the PhD program at the University of Westminster in the UK. So I was designing and preparing for fieldwork in Liberia and Sierra Leone, which are the 2 countries in West Africa. And I had to go through these IRB process, which compared to here in the States was really extensive. This was like a several months process of going back and forth. And the only data collection I was doing was just interviewing human subjects. So, it wasn't like clinical trials or collecting specimens. It was really just sitting down, conducting 30, 40-minute interviews with healthcare workers who were all above the age of 18. But I had to do a risk assessment, answer questions on ethics, who I was to interview, how I would access them. And I think my application got sent back twice for revisions or to update questions. And in fact, that whole process actually inspired me and a colleague of mine who's at Loughborough in kind of Midlands of the UK to write a paper for the journal African Spectrum called Risk Assessment Regimes. About how European universities are just making it so much more difficult to conduct qualitative data collection and research on the African continent because of all the restrictions that they require. So my plan was to interview healthcare workers, but then when I was in the field, I saw that I had the opportunity to access traditional leaders. So I put in an amendment for the ethics application. I got permission and I interviewed them. So at this point, I was like really proud of myself because I was going to parts of the country that you rarely see social scientists or public health researchers go into. And, I was doing it kind of by myself and really just targeting these hard to reach populations. That's kind of what we say in the research methodology or scholarly community. And I was doing this in a fairly independent way, traveling by myself and just kind of approaching different people. And so, when I came back to the UK by 2017 now, there was some praise and like, oh, congratulations, you did it. But then after a year, when I started interpreting the data and really trying to understand it, and I was bringing these key informants, the people I interviewed, we call key informants, how their stories centered on local communities. I just kind of brazenly announced to my PhD supervisors that, well, the international community did not save the day here. It was really these community leaders and traditional leaders who, kind of organized, went door to door, did kind of a local regulation or law rulemaking in order to bring down the case numbers. And that's when I started getting pushed back. So, my supervisor at the time, my main supervisor, was like, well, do you really want to put that out there? And when all the other literature talks about international aid and clinical resources, I was told that I may sound biased because I only interviewed community leaders and healthcare workers. I didn't interview any international humanitarian workers. And tell you the truth, I did interview NGOs that are based in Liberia and Sierra Leone, but these were, local reps. So they were Sierra Leoneans, Liberians who just worked for the NGOs and not the employees that are headquartered, say, in Washington, D.C. or London, because that just wasn't the focus. So on the one hand, looking back at it, I could understand why my supervisors were challenging me, right? It was to, prepare me to defend my work, as well as to understand nuance when I write, right? Because some aspects of statements like NGOs were always in this country, right? But the scale up that was announced came very late. Right. So just kind of differentiating between what I mean when I say NGOs just weren't visible, for example. And also the presence of non-Western NGOs was something that came about in my interviews, particularly from countries such as Cuba, Uganda, and China. So they had sent volunteers, I think, long before the US, UK, and France had announced in late 2014 that they were going to send aid resources and volunteers. But then on the other hand, it still bothered me a little bit that I was asked about interviewing international volunteers and humanitarians because there's so much literature on this. I think if you just type Ebola and West Africa, you would just find thousands and thousands of the search results where they, have the perspectives of international responders going into this country. So on a practical note, if the PhD is for, early careers like ourselves to create new knowledge, then it would be very difficult to do it if I was taking that same lens. But then, the other side of it is like, I am telling a story about a disease outbreak that took West African countries by surprise. So why did they have to be involved in that story, right? And so that kind of now leads me to part C of that paper when that says centering the voices of African actors, right? So why did I have to defend this? I did not exactly know at the time. But when crafting a narrative about what happened, I guess there was a bit of weirdness, I will say, about writing about Africa, right? So when we think about how previous stories, whether they be in the media, the lay community, entertainment, and yes, in academia, right? To write about Africa, to write about something in Africa. And then when you have all the main characters, protagonists, antagonists, and hero are all Black Africans, it feels like, oh, there's something weird. So now the anthropologist at that time, Paul Richards, who has over 40 years of research in these two countries, also came out with a book around this time about the outbreak. So this book was called The People's Science, looking at Sierra Leone and how communities understood scientific information and how they put that into practice, regardless of the lack of clinical resources. So when I showed that to people, including my supervisors and all those I was talking to, it came about of like, right? Because now my work has some legitimacy, right? So because there's somebody else who, kind of said it first, right? And so now me coming in afterwards, it just kind of made them breathe a little bit easier. And, again, I'm not saying that to make it sound like my supervisors had no faith in me. They didn't. Just remember that in this context, when you were a PhD supervisor, you're just trying to get your student in, get them writing, get that thesis in, and then have them graduate, right? Especially in the UK context, because the number of students that can be promoted and graduate, does help with your portfolio to get permanency. So while, there's definitely that encouragement of like creativity and, wanting to go out there, supervisors are also nervous about like, oh, what if when you do your Viva and, you can't quite defend that, so they're also thinking that too in the back of their minds. But anyway, so Paul Richards' books came out, and I remember going to a conference and seeking out another older white male scholar who's written a couple of books about Liberia and Sierra Leone as well. His name is David Harris, and I actually invited him here today, but he couldn't make it. But anyway, I asked him and I said, hey, I think community and traditional leaders were doing something in the first 9 months of the outbreak before aid resources scaled up. What do you think? And he was like, yeah, I could see that. And so I think as a PhD student too, I also needed some reassurance, which I think is something that all researchers go through regardless of your stage of your career. But it now makes me think, looking back on this for this paper, that we have to think about colonial structures that academia is built on, right? So that is the knowledge itself and how it's been colonized to erase contributions from the global majority and just kind of reframe it as achievements of Western actors or Western civilization. So, again, in retrospective, it should sound really silly to us to kind of think that for almost a year of this, crazy dynamic disease outbreak, like nobody was doing anything about it. Nobody was, trying to go door to door or help people, right? That they were just kind of sitting around and waiting for aid to come. No one has explicitly said that, but by not talking about that specific time period before these three, major countries intervene, we have essentially erased it from the canon, right? And so that was when my supervisor suggested, to make us a timeline. And so that would lead to part D of my paper about decolonizing the timeline. And so this I relied on from subaltern scholar or post-colonial scholar Dipesh Chakrabarty, who wrote a great book in the 2000s called Provincializing Europe. And so when I look back at it with the literature that just came out at the time I was doing my PhD, most of the scholars were writing about, their data or observations that were done around 2015 and a little bit in 2016, right? Because by 2016, the case numbers were really dying out. Like, I don't even think they were collecting it day by day. They were probably doing it like every week. So the agencies such as the World Health Organization, the CDC, they had some data starting in late 2014, right? So I think the CDC put out some reports through MMWR, their Mortality and Morbidity Weekly Report, if you subscribe to those. Yeah, those started coming out, I think, in July. And then the WHO started putting out data in August. But for the most part, most of 2014 had not been written about. So we had the world's largest Ebola outbreak in modern history, and there was so little data and narratives about what happened that first year compared to 2015 and 2016. And so I realized this when I was reading one of the WHO's report, and they had this official timeline, like stage 1, stage 2, and etc. And according to them, stage 1 started in October of 2014. So now, just to recap, the first EBD case that we know happened in the southern prefecture of Guinea was in December 2013. So now the WHO, are speaking from the position, as an agency of when they declared the outbreak a public health emergency of international concern, also known as PIAC, in August of 2014, right? Because that's when they officially intervened, and then having that declaration per the international health regulations allows them to partner with different organizations, raise money, get funds, and then actually go in. So the WHO is an authoritative figure, and this is how history works, right? Like 50 years from now, we don't want people thinking that, this outbreak hit in late 2014, and then that's when WHO, different countries all kind of jumped right in. So I made the case to decolonize the timeline and say that stage 1 begins from December 2013 to September 2014. So the PIAC was declared right after that. And then stage 2 would be when international donors and military and so on came in and did their scale-up intervention. So now that we have literally set the stage, the next question would be, well, what happened? And that now brings us back to the narratives of the key informants that I've interviewed. So again, the healthcare workers, as well as now the community leaders, and the available epidemiology data. So the epidemiology data was another issue. We worked backwards and forwards on the epidemiology data. So first we calculated the rate of change to try to see, what the curve is. So now that we've all lived through COVID, I'm sure we understand the phrase bending the curve, right? So we're referring to that line graph to see when cases were climbing, holding steady, and then hopefully going down. So we were able to do that with the epidemiology data from, I think, March of 2020 up until August of 2020. But there was a few problems. So, for example, in July of 2014, the healthcare system completely collapsed. So there was like no data at all being recorded for like 6 weeks of that summer in both countries. And so you have the curve of the graph like artificially just kind of dropping and then going back up again. But we know from, the narratives and things what happened that this was not necessarily the case. Lots of people were dying. Cases may have gone down, but they didn't just crash to zero. And then the second part of that is when you do this type of epidemiology calculations, we were looking at it from district to district within the country, or like county to county within the country. And so we needed the population data, right, in order to kind of standardize it first, right? Because you can imagine, say, Freetown, which is the capital of Sierra Leone, has like 1 million people. And then you look at the rural area of Sierra Leone, like the Calahoun district, which maybe only has 100,000 people. So now you have to standardize both of these populations in order then to get a more accurate understanding of the prevalence or incidence rate. And so 2014 was the year that Sierra Leone was supposed to do a census, but because Ebola happened, they canceled it. So the last official population data that we had for the country was during the war period. So that would mean that that data was over 20 years old. And so the period, obviously, with people moving around and being displaced and dying. And so that brought me to the idea of the case fatality rate. So after starting with these numbers, you know, at first, like I said, I was comparing within countries, but then I just zoomed out and I compared Liberia and Sierra Leone. And that is when we noticed a difference with prevalence, mortality, and the reoccurrence rates. So Sierra Leone had better outcomes, and at least 2 of those categories, specifically the mortality and recurrence rates, could be traced back to interventions that traditional leaders and community leaders had implemented. Like the early medical interventions helped to increase prognosis of EBD patients, right? So in other words, if you think you're sick and you go to the doctor or the nurse in those first few days of, you know, those vague flu-like symptoms and get diagnosed, your chances of survival increase. And then this very strict social distancing measures that they implemented to stop all movements and personal interactions outside of the household. So we calculated this, you know, case fatality rate. And the good thing about the CFR is that it can be applied to different policies or environmental factors that was happening. And so now that kind of brings us to part F, which is my COVID research that I'm currently doing, and how to approach that through a decolonial lens. So, you know, again, sticking to those kind of 2 things of like the timeline and the epidemiology data and what it could tell us. So I think timeline for COVID, we're going to have to deconstruct it in the same way, right? Because if you look at, say, when the first cases were in China, and then it went to Europe, and then to the United States, right? So the narrative is kind of like, well, this was the first wave. However, most countries in Africa, with the exception of, say, like South Africa or Kenya, didn't have that same kind of first wave that we experienced, right? So based on what my sources, what my key informants are telling me, is that the timeline of first wave and second wave and third wave and fourth wave didn't happen in the same consistency. So it looks like Sierra Leone and Liberia had 2 waves, while maybe the rest of the world had 3 or even up to 4 waves. Another aspect of their narratives that you know, also stood out to me was, again, the role of international aid and resources. So because COVID was a phenomenon that really impacted Western countries, a lot of the resources, testing supplies, gloves, masks, so on and so forth. Very few of that was actually sent over to low-income countries like Sierra Leone or Liberia. Like Western countries themselves were like swamped with it. And if you remember, even the United States, they had enacted an emergency kind of declaration where they called out, or they basically shored up their supplies, and they were kind of hoarding it, right? So they weren't really scaling up aid resources or clinical resources for other countries in the same way that they had received aid for Ebola. So in this case with COVID, particularly in West Africa, they had to rely more on behavior changes, you know, like the hand washing and the social distancing, et cetera, than clinical interventions. And, you know, I think that was kind of the same for all of us generally, because there was no real treatment or vaccine option for COVID until about 2021. But when I went to Sierra Leone in late 2022, they were just starting their vaccine intervention. So I remember in the second week of November, they were on what's called Surge 13, which is a weekly surge that they were doing. So that was the 13th week. Whereas for us in the West, we were doing vaccination treatments like January of 2021, first for like the elderly, and then the general population got in the spring of 2021. And so these are some of the patterns that I'm so far noticing. And, you know, I think timeline is just one of the really more important parts of it, but it also gives us a perspective when we look at what's happening in periods that are critical to the center of, you know, our subjects of study, in this case, Sierra Leoneans and Liberians, and, you know, how that just changes things around. So that's what I had so far. And I'm hoping that my thoughts for part 2 doesn't sound like I'm ranting or raving, but if it does, then you can tell me why. And then that's kind of also how I'm trying to lead in from my work from Ebola to the methods and strategies that I'm employing for my work with COVID. So yeah, I appreciate any thoughts that you guys have or any questions I can answer.
Thanks, Sabine. It's your talk and your going through your, you know, thought process makes me recognize how complicated the whole telling of the story can be. One thing that's kind of coming out for me in what you've said is, you know, how is Ebola different from COVID? We know that they're both infectious diseases, but they're infectious diseases that have different vulnerabilities, you know, for different sectors of the population. They have different levels of lethality. So how does that get, I mean, I think I really like the whole thing of your stages or your waves, and that the wave 1 doesn't occur globally at the same time. So, you know, how do you take the variability in when a country enters into that wave 1 and then the wave 2? Because I think it's probably the most important, and I may be wrong, and correct me if I'm right, but what you're really interested in is capturing that wave 1. That it's not that it, you know, that these public health threats operate in a vacuum until the WHO or the CDC or some international health or national health group gets a hold of it, but that there's things going on, and you really want to make that part of the record. Am I right in that? Yeah.
Yeah, I mean, that's totally right? So, you know, we definitely, you know, and I think this is where I rely a lot on the key informants interviews, you know, when I talk about, okay, what happened before COVID, what happened during COVID, and what happened afterwards, right? So when I phrased it that way, they said, well, before COVID, A, B, and C happened. And I say, oh, give me a date. Right. And so that date could be from January 2020 up until about May 2020. So for them, that was there before COVID. right? And then during COVID was when they had that first case of someone who just had visited from France, and they had tested him and, you know, found out that it was COVID. So that was their, you know, I guess patient zero, for a lack of better words. And then, you know, they did the whole quarantining the airplane, track and tracing everyone, et cetera, et cetera. So they talked about that, and that would be, I guess, the way I would try to identify the beginning of their wave of COVID.
Wave one of their COVID.
Yeah, if I could even call it that, wave one, because it's, you know, like a lot of it was centered in, you know, the urban areas where there was still movement and travel. So, you know, like air flights and things like that. However, we see that it didn't really go beyond Freetown, which is the capital of Sierra Leone. So even for me, I'm still kind of debating on like, how do I use that word wave? Because, you know, when we kind of think about it, at least in the lay community, it kind of feels like, you know, this whole like giant thing crashing over. But when we saw how it was governed in terms of like the social distancing rules, you know, the limit on personal interactions, the traditional leaders did gather in that same way to create bylaws and et cetera, like they did for Ebola. But within a few months, it was just kind of like, oh, what are we doing? No one's really sick. And then, you know, although traditional leaders are authoritarian, they still care about their reputation. So they became a lot more lenient on things like the fines and things like that. You know, where to a point, one traditional leader was like, well, you know, these people don't have what was it, like 200,000 leones, you know, because they didn't wear a mask. So, you know, I just let them sit here for some time and then let them go, you know, like kind of like the way like a timeout, like sit you in the corner and then go, because they didn't think it was, you know, that fair to be so strict during COVID. And then, you know, the second kind of breach, or I guess wave, you could say, that happened in the following flu season. I mean, even by then, most of the kind of structures, you know, like creating a COVID treatment center and all of that, like a lot of that was, you know, it was very expensive to run. And a lot of these COVID treatment centers were just completely empty. So to the point where they had the government had to change course and just do, okay, at home caregiving, you know, if you have a cough or any type of kind of general flu-like symptoms, you know, stay home for this amount of days until it gets worse. And then if it gets worse, then you go to the healthcare center. So it's definitely a very different story compared to Ebola. It wasn't this protracted public health emergency that we saw back in 2014. And I was actually having a conversation last year with Johnny Steinberg. Do you know Johnny Steinberg, Loretta? Okay, he splits his time half and half between Yale and Oxford. So he teaches, I think, at Yale in the spring in the spring, and then Oxford in fall. But so he's a journalist and he writes a lot about health politics and health policies. And one of the things we really agreed on was that, you know, with COVID, it was a disease that really affected the urban centers of places, right? So Western countries, places where you have offices and people work crowded together in a building. And when you think about like most of the smaller countries in West Africa, again, with the exception of like, say, South Africa or Kenya, you know, where they don't have that type of built infrastructure or built environment, you know, COVID was not, you know, really that impactful. So while there are COVID cases in Sierra Leone, the death rate was very, very small. Much smaller compared to the US or the UK when you take into account the population. And so we were kind of looking at this weird kind of rural and urban phenomenon of Ebola versus COVID, because Ebola tends to be a disease that only happened in rural areas. And politically and economically speaking, rural populations tend to be marginalized, right? But then, COVID happens in areas that are densely packed, urban economic centers, like how South Africa is an economic center for Southern Africa, or like how Kenya is an economic center for Eastern Africa. Then, all the governance, emergency plans, all the money that we could never seem to find to build healthcare systems suddenly just kind of pops up. And so that's also kind of another understanding of how I weave economic theory, using kind of public health research methods in an attempt to, just kind of decolonize the narrative of how we understand public health emergencies, how we understand how resources are allocated, as well as how the interest of local actors versus international or national actors.
Thank you, Sabine. Actually, so we've got two different diseases at this point that are very different in their origins and I don't know, in their rate of transmission, because Ebola, it's more than just respiratory. I don't remember, it's transmitted like, I don't know how, but at any rate, you've got these different locations that they can have the outbreak. You have these different levels of economic security of the countries. And there's important things to be taken from your work in terms of deciding for policymakers in different countries to take your work and act accordingly in the way that they think it would be best to react. That not always is it something that you should set up these elaborate centers in these rural areas. Perhaps that is not when you've got multiple problems, you want to allocate your resources in a way that is most efficient. Emily, you have your hand up, please. Anybody, I was about to say that I'm just taking up space, I guess, right now, but people should just unmute themselves. Emily, why don't you, it was Emily.
Yeah, I put it down. Yeah.
Okay.
Thanks so much for sharing, Sabine, this really amazing project. I have a two-part question. So it sounds like your key informant interviews have been like really crucial to you reforming these timelines around these diseases. And I'm wondering if you've like supplemented that or looked at like other kinds of sources, especially thinking of your background in history, or like have you engaged other archival sources or textual sources? And then my second question is related. Have you, especially because so much of like the decolonizing part of your work right now, at least what you've shared, centers around timeline, have you collaborated or thought about collaborating with historians and like the decolonial theory they've used in their work?
Thank you, Emily. So for my first research, I did engage with some historical sources, but they weren't primary historical sources. So, I've engaged with literature that have written about Sierra Leonean and Liberian history, particularly in the post-conflict setting of their history, because that is when so much had changed with their healthcare system. But most of the work was contemporaneous. So looking at how the legacies of war and the dismantling of their healthcare system have left them unprepared to fight Ebola back in 2014. So for this research, though, although I'm engaging with history, is not the local history of Sierra Leone and Liberia. I think I was trying to set up in the paper the history of global public health to just understand like how it came to be and to again look at those institutions that are today in present day affect global public health, such as the WHO, the World Bank, and the WTO. But I do need to think a little bit more of how I can tie that back in to, go back and then explain, like, again, with Ebola, this was like an emergency that everyone was afraid about. And so, they pour money and they poured resources into it. And just going back to Loretta's point about, the same policies over and over again, the reason why they did that same policies for COVID with all the treatment centers and all that, they refer to that as the Ebola infrastructure, right? So this was like the legacy, the infrastructure and policies were like the legacy of Ebola. And from 2016 up until 2020, right? So they were kind of being trained more on like disease surveillance and that kind of thing, which is great. But, it was built on the Ebola infrastructure or the Ebola legacy. And so when they were kind of doing things the exact same way as they did with Ebola, but then they kind of saw like, no, we need to do things differently because this disease is not like Ebola. That's when you started getting more kind of indigenous or local approaches to governance.
Actually, to add on to that, and then Debbie, I'll turn it over to you, but to give a nod to the public health groups in every one of these countries, we really didn't know that much. It was relatively quick for them to come up with a vaccine, and they are to be congratulated from that. And I guess, you have to say, well, we don't know what we're dealing with, so let's go with the kind of worst case scenario, i.e. Ebola, until we get a handle on this virus and understand, what we can and not necessarily don't need to do.
Yeah.
I mean, you have to balance things, and it was well intentioned, but you raise the point of there should be something for how new or well known is whatever is the next outbreak organism going to be, and then have a different way of reacting based on what is known or what is not known. Debbie, sorry to take up that time.
Well, I'm actually going to go back to the whole decolonizing issue, because one of the things that I think is really fascinating with your use of a timeline is in many ways you're calling out the colonial practice of year zero, that nothing happened before the white people showed up. And so I think that even embedding that year zero, I mean, one of the most fascinating things for me is that Native Hawaiian is defined with respect to year zero.
Yes.
When the white people showed up. And so you're calling that out, and people are going to say, oh, but we're done with that. But you're noting the implications in a very real way of that concept continuing on mentally. Until the scientists measure it, it doesn't exist. But it is this overarching colonial construct of nothing matters until we affirm that it matters.
No, I think
Yeah,
that's
Debbie, spot on.
Yeah,
spot on. And Debbie, too, I also think the same approach was taken to the epidemiology data, because back then people were saying, oh, that they weren't well, calculated, they weren't doing different things. And, the WHO came in and they had their definitions for probable, confirmed, and suspected cases. But then interestingly enough, when COVID came out, guess what? Disease outbreaks are highly dynamic and fluid, right? We're not going to count every single case. Healthcare systems are going to be under duress, and, cases might go under the rug or anything like that. But we still found an effective way to talk about the COVID-19 pandemic using the available data. But I think you know, a lot of papers that I was reading at the time. And I think now the story's a little bit different, but, you know, they were just saying, well, these are the numbers we have, but we don't know if they're that accurate. And they wouldn't, you know, it was very few people that tried to do something with the available numbers.
And I think that I'm encouraging you to call out the mental, the colonial patterns of thinking that justify, that are used to justify skepticism towards anyone else's data.
Right.
And so I think I'm just encouraging you to be more explicit at the ways the thought patterns you're observing are being anchored by history.
Thank you so much. I'm just writing this down.
Because, you know, you touch on it, but if you really want to call out the thought patterns, what you have to call out is what kinds of actors are perceived by the system as less valid. And so those are the actors you're trying to talk to. But if you can make visible the criteria that are used to make them less valid,
Right.
that's part of the decolonizing practice.
Right. So like the Sierra Leonean or Liberian version of confirmed and probable cases, and then how the WHO came in with their new definitions. I see.
And tossed out all the previous data. You know,
Right.
basically gaslighted all that previous data.
Right.
And so you're walking a dance because there's a definition of rigor that the Western scientific community adheres to, but they're the ones that have also imposed it.
Right.
And so you've got to walk this dance of highlighting the questions of who gets to decide what's valid data, who gets to decide, and what is it that says representative? How do we define representative? Who gets to define that? You know, there's a lot of definitions that fall into this infectious disease space that are seen as scientific. And part of what you're calling out is the history almost of those definitions and those classifications.
Well, there's an underlying assumption also in Debbie, what you're saying of there is one valid path, you know, there's one valid, and that's not, I mean, we in qualitative research, I think, should be most sensitive to there are multiple truths out there depending on your perspective, your context, your situation on a given subject, and that perhaps it's more in allowing those other ways of approaching the problem and measuring the problem and reacting to the problem to be seen as another approach that is not a bad approach, but another approach. And
walking the hierarchy of approaches, for example, noting the ways that the hierarchical colonial approach is really good. I also have to jump for another meeting, but this has been, it's been interesting, and it's great to have this this parallel walk that you're doing of the data and the path of an epidemic and the different ways of understanding that path based on the lens that you're bringing to the story.
absolutely.
Thank you, Debbie. Thank you, Loretta.
Yeah,
And
thank you.
Meredith, Meredith had to jump off, but she said it was fascinating and that she really is looking forward to you circulating the paper when it gets done. I think there's a lot of us on this call or in this group who have followed you from last year to this year and want to see your progression and where you wind up as you go down your path on creating this article.
Thank you. And yes, thank you all for the comments in the chat. Someone asked me about looking at serological data. So that's a good point, and I will try to see if I can get access to that. It looks like some people were seeing different slides. Sorry about that.
That's okay.
And could this
Yeah,
be an entire book? Yes, it probably could. So, but let me write serological data.
Tia had a question. I don't know if she's still there. Yes.
Sorry, my Zoom is acting up. Yeah, I was just curious because there is quite a bit of serology data around COVID-19 that came out of Sierra Leone. And so it would be really interesting, I think, too, to kind of compare that to some of the different narratives and see how that fits in. Because I think some of it was quite surprising, I think, in the field initially. So it's in the literature, so it might be something else to kind of weave in as part of understanding the perspectives.
Oh, definitely. Thank you for that.
I don't know if we're helping or complicating it, but it is a story that I think deserves, a hard and thoughtful consideration of all these perspectives and all these approaches and what best would fit what you're seeing.
Yes.
Well,
thank you all. Thank you.
It's a delight, Sabine. Every year, it's a delight to hear about what you're doing, and please continue to update us. Any
I
other?
will.
I think people are jumping off for other meetings. Have a wonderful weekend. Next month, it will be, I hope, on Photo Voice. And we will be sending out a reminder about that. Thank you to everybody who put their email address in. We will add you to the list so that you can be updated on our reminders. With that, I'll say goodbye to everybody and have a good
everyone.
Bye. See you next
Bye,
month.
everyone. Thanks, Sabine.
Bye. Thank you guys again for having me back. I really appreciate it.
It's
I'm
lovely
just
to
writing
see you.
Dada's comment, historical ontological.
That was a great turnout.
Yeah, no, clearly your
Yeah.
topic is of great interest to many people. You know who Dada is?
No, but I
Oh.
saw the
Yeah,
comment
yeah.
they left for me for Andrew
Yeah.
Laptop's work.
Yeah.
She works with LaRon Nelson
Oh, okay, all
at
right.
nursing, Yale School of Nursing, and they have a congress that they put on every year, History, HISTORI,
Okay.
in I think Atlanta again. I'm not sure, but
All right, you're in the
Oh, okay.
office, Pete?
I'm sorry.
Are you in the office?
Yes.
All right, I'm coming down.